Thank you, Nahida, for this kind invitation. And me and Nahida have been discussing this for almost 2.5 years. We've known each other. How can we work collaboratively to help look after our renal patients more holistically? I have recently joined the ISN's advocacy group. It's not something I was kind of interested or actually came into my radar because I worked mostly in mature healthcare systems before I came here. Then I realized a completely different paradigm which I was dealing with when I joined SEHA. Just wanted to make a small plug for my society. There are two major initiatives going on. One is for acute kidney injury and one is for chronic kidney disease. I'll tell you, gradually that 10% of the world's population has kidney disease. And in the global south, it is going to be a huge problem. By 2050, it's expected 1.5 billion people in the world will have kidney disease. So the outline of the talk, I do not have any therapeutic options or any solutions I'm going to offer. I'm hopefully just going to tell a story of how big a problem this is in this region and why we should maybe focus on this domain of medical health. What are the possible next steps? So to those who are not from UAE, more than 200 nationalities call this country home. And intentionally, there's no women on the picture because mostly it's men living here, actually. Very few families live here, unless you're a white-collar worker. And actually, the biggest population is Indians. We have some of the richest people are Indians. There are people, white-collar people like me. But the people who build this country are single young men who have left their homes to feed large families back home. They are actually the ones who are building this country. And it's well known that expatriate population has increased kidney disease. This is not just African Americans who left the continent to Americas 300 years ago, but even people like me who've migrated to the UK, US. 30% of British Indians are diabetics or hypertensives. And same here. We've been naturally selected to survive in salt-poor, calorie-poor areas. And now we are eating energy-dense food and hardly moving. And kidney disease is pretty common. And I've been using the vernacular media to raise the awareness. Malayalam Manorama is the third largest circulating newspaper in the world and the biggest newspaper in UAE. People don't know that. This is what most people in Indians read. And me and Nahida's husband had an opportunity to write an article in the last World Kidney Day. And this is old data. This is data from 2015. And you can see as you grow older, expatriates get more kidney disease. And largely they lose their jobs and go back home. But if I stay back here when I'm 50 or 60, I will have CKD and hypertension. And obviously these people are high risk of having strokes, heart attacks, peripheral vascular disease. And unfortunately, there's a 10% growth rate of end-stage renal disease in this country. In America, it's plateaued. The prevalent dialysis population here is growing up 10%. This is unsustainable. Out of the various modifier risk factors for kidney disease, you'll find that low socioeconomic status, stressful life, social isolation, anxiety, and depression is mentioned as a modifier risk factor for kidney disease. And as my talk will illustrate, this is something we should probably be focusing on while we're giving them aspirin, statins, and better diabetes control. I want to mention to you about global warming nephropathy. So there are a few hotspots across the world, Mesoamerican region, Africa, obviously, Middle East, and Southeast Asia, where there's a 10% growth rate of end-stage renal disease. I mean, this is largely because of multiple AKIs, poor lifestyle, the jobs we do, construction sector, farmers, and one of the most common cause of end-stage renal disease is truck drivers who travel from Oman to Kuwait. They have the truck drivers have a GPS tracker, so they have to reach their destination. So they don't take breaks. They're just driving constantly for 3,000 kilometers. And most of them are Sardars or Pathans, these who come in, and you'll see them in ED crash landing on dialysis. And this is data from our transplant program in Seham. And as you can see, Emirati is only less than a quarter people will be transplant. Most of them are South Asians or from Far East Asia. And their donors obviously are from the same region. This includes the disease donor population. So our population is very unique, and this is so we'll have to think about solutions which address South Indians, wider MENA region, Filipinos. You know, the language we use, the stories we tell, has to be tailored to the population we're dealing with. So this is a slide from the last group which were running Renal Services. So they made this presentation to the Department of Health. I pinched the slide. So those two arrows are from me, but this is the graph they showed that this is in 2010, they made a business case that by 2020, we'll have roughly 2,000 people on dialysis. But the population has actually stayed at 1,200. So we have a 10% growth rate and a 10% attrition rate. People, when they end up on dialysis, they lose their jobs and they go back home. And they're going back home at the age of 40, where the huge families they were looking after, you know. And just during COVID, just in one center, we lost 200 patients. And I was speaking to Kamal Shah, who runs the biggest dialysis program in India, a private company. He said he lost 30% of maintenance hemodialysis patients during COVID. They all died, you know? So we are very fortunate. The government of Abu Dhabi is very benevolent. They offer free ESRD care. I mean, it's no secret that the father of a nation was on dialysis and he had a transplant. So very generous. We have free ESRD care. And each dialysis patient costs the government of Abu Dhabi 350,000 dirhams to look after per year. And these are non-expats, mostly single male, who can never go back home because they cannot afford dialysis. And they're stuck here till they die, actually. And at any given time, 30% of them are Indians. So when I was mostly brought to grow the kidney transplant program, and immediately quite realized that these people have no living donors in this country, and they have no insight about dialysis, and what are the ideal options for them, and obviously through health literacy. No one. I was actually first Indian nephrologist appointed in Saha Kidney Care. Obviously, we have subsequent people. So no one could even communicate to them. Obviously, Filipinos are there; they can speak English. But Arabic people, again, it's not a one community. The messaging for Sudanese will be different from a Jordanian or a Palestinian. That we didn't understand, and most of them enter our healthcare system only when they start dialysis. So there's a huge distress, both from the patient and the loved ones back home. What did you do to our loved one while they're on dialysis? And there's hardly any vernacular language information available about any form of mental health, kidney disease, or anything else available. And all crash down on dialysis via our ED. So they don't get any kind of preparation about what CKD entails, what are the treatment options, and various things. And just to give you some numbers, so over 100 million people right now have kidney disease in India, and same in China, 100 million, more than 100 million people. And they're all in the age group of 40 to 50, where they have huge responsibilities looking after young families. So the psychological impact, not just on the patient and the family, is huge. Roughly all the transplant programs in India put together do 8 to 10,000 kidney transplants. And the need in India alone is for 150,000 kidney transplants per year. Rest people just die. So how does mental health impact kidney disease? You know, as you know, there's no magic cure to prevent dialysis. It's just better healthcare choices, looking after your diet, taking your pills, going for follow-up. And that becomes a huge problem when they have a huge anxiety, stress, financial impact, all things hovering over their mind. They don't go for their follow-up. And obviously, we know progressive CKD is an inflammatory disease, inflammatory condition that makes increase the stress modulators, and there are other biochemical changes which make them lose appetite, lose sleep, which further compounds this problem. So this is a study which is quoted in most mental health literature on renal disease. This is from inner city Brooklyn, which probably is representative of our kind of population base. 70% of people on dialysis in this dialysis center had some mental health issues, either depression, anxiety, substance abuse, or psychosis. And this is from New York, but I can tell you this is what we see in our population as well. So the best kebab restaurant in town is Tikka Tonight. It's in Musafa. So I go there very often. And when you go there, you'll see these labor camps, and there are 8 or 9 people living in one room. This is their supposed structure. They are usually from one town or one family living there, and this is how they live. I've been to their houses because some of them cook really well, actually. Most of our drivers are Pathans, very good cooks. So I go and share food with them, and this is how they live. And if you end up on dialysis, what kind of support structure you have? Can you do peritoneal dialysis here? They have to catch bus, sometimes catch hook up a hitch ride to come to dialysis, even though dialysis is free. Yeah. Dialysis therapy, I mean, unfortunately, the way we've designed a dialysis therapy is to make more money and optimize services, which is not how patients have to live. So they go to work, they have to go to work 8 to 4, 8 to 8, and our treatments are done during the daytime, which means that they lose that day's earning. You know, if you're a taxi driver, if you're a truck driver, and they are pretty depressed, you know, and they are the only breadwinner for the whole family. And the amount of anxiety and the stress they're living in is huge, actually. And it's 3 days a week. So one day they prepare for dialysis, next day they're exhausted from dialysis. And this is a never-ending cycle for them. Thankfully, unlike in the West, our dialysis units are palaces because of this generous support of the royal family. I mean, this is a new dialysis unit opened up in Ras Al Khaimah. I mean, it looks like a hotel, which I was staying in last week. And this is not like the small dialysis unit you see in dungeons in where I train WashU or guys, you know. Here we have huge palaces, you know, but we should be spending more money preventing this from happening rather than building dialysis unit, which costs the government of Abu Dhabi 150 million to build one unit. So obviously, autonomy is what I enjoy the most. You know, as being an adult, I love doing what I want to do when I want to do. You know, one of the reasons I left my last job is I didn't have autonomy. But and unfortunately, when you're on dialysis, you're my prisoner 3 days a week, and that impacts most of these young men. It's not these old women or men who are on dialysis in UK, who for them is a day out. You know, here this is their livelihood. And I'm stealing that one day from their life, 3 days of their life. Impaired limits, you know, most of these workers are laborers, construction workers, so they have to drink water because their mouth is dry and they come in fluid overload, you know. And obviously, and then I scold them, why have you put on 6 kilograms of weight? And you have to stay longer. Boss, I can't stay longer. The last bus from Mafruk dialysis unit is at 9 o'clock. If I miss this bus, I have to walk home. But and then they have not been home for years. You know, a lot of what I am is because of family members who care for me, you know, and I love being that. So they can't travel. So there's complete, you know, so they miss all the children's milestones. They have not, I've got a patient who's not seen his daughter grown up for 8 years because he can't go home. He just stays here, you know. And lot of, I mean, sexual health is a huge, as you see, they're all men living here, you know. So they've not visited their wife. I can tell you a story later on. As you know, most frequent donors are women to men, you know, all over the world, not just here, all over the world. It's women who donate to the most common donors. They don't have a relationship with their wife to ask for a kidney because they have not met or consummated their marriage for years. They don't sleep because they have restless legs. They have our medications keep them awake. Fluid overload makes them short of breath. They can't sleep. They're anemic, so they're exhausted. They can't sleep. They're confused because what happens is when we do dialysis 4 hours, we cause a form of dysequilibrium syndrome. you get cramps, you get confused, you have headaches, so you're not sleeping. So insomnia is a huge problem for these patients. I mean, I don't know if you've seen dialysis needles, they're hose pipes, and that they have to be, two needles need to be get stuck, if a nurse does it well, 3 times a week. And frequently they don't do it well and they're in a lot of pain. The arm is swollen, bruised, and that's a problem, which adds to that problem. And the medications, as Dr. Diane can attest, I like to stop medications, at least one medication for my patients, because most of these medications for dialysis patients are not validated. They don't work. Statins, aspirins, vitamin B, vitamin D, folic acid, but we are giving them huge pill binders. They have to borrow money to pay the copay for these medications. The medications are given for free. And in the US, average pill burden is 19 pills per day. They have zero appetite, and we're giving this medication this big, which causes indigestion. Sevelamer, commonly used phosphate binder, very expensive, doesn't work. No trials it works, but we give it because we have to control phosphate, because that's a KPI, and that causes acidity and fills the stomach more than the food they eat. And obviously, we tell them don't eat. This is what we have taught in the West, where we are trying to delay dialysis. We say don't eat proteins, don't eat, because these are old people. It's easier. If you're 40-year-old and I say don't eat meat, don't eat dairy, don't eat fruits, don't eat rice, this is what their common diet is, and I'm pointing fingers when their phosphate levels are high, doesn't matter, it shouldn't matter, then actually that makes them even afraid to speak to me, on my rounds. And obviously they're living together, they have to share food, they can't cook their own food. So I don't know if all these guys who live together, they pool money to cook for food for themselves. So largely the food here is mandi or chicken biryani with Diet Coke or Coke. That's how they eat. And unfortunately, Coke has phosphorus. The 3-in-1 Nescafe, which they largely drink, has phosphorus. And they just come and say, doctor, I had to eat because we had something. And a lot of the interaction these patients have is with nurses. And most nurses who come here are spending 2-3 years and going to the West. The only nurses who stay back are who are not so great. So there's no bonding happening with the healthcare provider. So the nurses are just treating this as a business, like a job. There's no counseling, no opening of hearts. So that was a huge problem for me when I came. Like, I didn't even know which of the patients would potentially have a living donor. Because normally in the UK and the West, US, the nurses will know he may have a donor. Let's have a chat. But the nurses don't know, So because they're just staying here 1 or 2 years and going to the West. I want to learn helplessness. This is I want to talk about this. I had a patient. He was a luggage handler in Etihad Airport, Abu Dhabi Airport. And I knew his wife was potentially a candidate for donation. Okay. So he lost his job just when the COVID started. And I've been preceding 1 year, I said, can I have a word with your wife in India? And I speak the language. I can maybe help you potentially get transplanted here. So when COVID came, obviously a lot of people were let go. He came and said, I'm going to go home, I'm going to die. Do something for me now. I wrote a letter to the Etihad Airways HR, but it's just too late, Now, I didn't realize, why are these people not looking for option to help make them get better? So I read about this experiment which was done by Seligman. I mean, maybe you psychiatrists know this already, but for me it was a new thing. So basically, just for the non-psychiatrists, so this guy, he put a dog and in this kind of compartment, and in one compartment, the floor, he was giving them shocks. The other compartment, there was no shock. And he tried different iterations, but in the end, the dog just lay on the floor getting shocked because he said, there's no option for me. There's no way out of this. So they'll come, stick their hand out 3 times a week and not look for options, even though they have brothers, sisters who are dependent on them from earning to get transplanted. Honestly, feeling of impending death. So if I start dialysis now, my life expectancy is 8 years. If you start dialysis at the age of 70, your life expectancy is 2 years. Worse than most solid cancers. So they know that they're dying. So they just say, okay, so I'm sure you've seen these two pictures from Edmund Munch. So this is his sister who was dying, and he himself had bipolar disorder. And you've seen the famous painting. If you go walk to the dialysis unit, it is just like a God's waiting room. They're just the whole business has become so emotionally disconnected that they just come here and they're like almost an ATM machine for the organization because we get a lot of money. One more big challenge is the caregiver depression. Usually, especially for the Emiratis, the unmarried woman in the house is looking after this old mama on dialysis. And I'm sure you've looked after patients when they end up in hospital. There's used frequently a code white, because when the family mom codes, the whole family is in denial. And because they've invested a lot of money in keeping that old mama alive. But no one has told them that dialysis is actually a terminal condition for these old people. And that also impacts how the care is given for their loved ones, and compliance and various things. So, Imari, what I've just hopefully put a picture is like the patient who's on dialysis has multiple issues around them, which is making them make the choices they're making for diet, long-term outcomes. And we have to sort out those ecosystem problems around them if they have to make the right healthcare choices. And that unfortunately requires a 3 to 5 years action plan, which hopefully we work together and solve this. What is the hope after this talk is we start looking, as my cousin John Rock says, we have to do this together. We have to first understand what are the barriers, both from payer-provider relationship, insurance providers, address the gap, and then look for local solutions. And we have to raise awareness about, obviously, there are better options to be. And I want to show some of the stories, because I was probably brought to increase the transplant program. We start talking to people, going to schools, churches. I have this lady here in the middle, Anan. She made me world famous. I don't know if you know, I'm very world famous in nephrology. And she made me that because she helped me increase the transplant program. And this is a story of a young girl who died, who saved multiple lives. And that story, we started talking to every schools, because it's the children who make parents do what they do. So then parents start signing up to be donation. We increase the living donation transplant in Seha by talking to people. Emily is one more champion who I used to work with. And I should mention, obviously, Ayaz, Wasim, and Chandra, who joined after me. We helped increase the transplant program in Seha by almost 90%. The roles of public society, we go and talk in churches and religious communities. And sorry, I'm running down. Okay, I'll be short. And I want to tell you a story about this young woman who had 3 loved ones who wanted to give her kidney, but she didn't have a potential option. And then locally, so we had to work with a program in India to facilitate this transplant from happening. Now, this story made a huge newspaper in India. So we had put together transplant in India and Abu Dhabi, and that created multiple success stories in India now. So what I'm hoping is we create some nice stories together that will capture the imagination of the main stakeholders, that this is possible. So final thoughts. It's all about telling stories, and hopefully the presentation I made today was just a storytelling, so we can work together, engage the local counselor services. They're willing to help. I work with Indian council services regularly. Leverage the expats. If I am telling the story to an Indian, it is more impactful than a non-Indian telling that. And if we have people who will do the cultural translation for us, involving societies, professional bodies, that will help increase awareness, both about CKD and mental health issues. Okay, thank you very much. I hope that you found the talk interesting and insightful. Thank you.